hands, feet, especially loss of sensations or abnormal sensations. The pins and needles feeling gets worse at night. Foot injuries, ulcerations without pain, they do not know they're there. And healing is near impossible once the breakdown starts. I've seen some horrible diabetic skin conditions, just horrible. Neuropathy treatment, again, tight blood control. Creams, depressants, anti-seizure medicines. You keep throwing things at the disease process, hoping something works. Can affect all body systems, complications, gastroparesis. Huge problem with diabetes. Basically, the intestines in their stomach just stops working. They will eat and it just lays there. Very common. Nothing is in there getting digested. It's like, oh, so slowed down. Everything is slow motion. And it affects them at night because everything that they've had during the day is kind of just still laying there. And that's when they're very uncomfortable trying to empty their stomach. Have cardiovascular abnormalities, sexual function issues, as well as urinary bladder. Foot complications, that top one looks just like my brother's when he first discovered, gee, look what was under my foot and I didn't even know it. That's what he started with before he lost his leg. Very, there would be nothing for a person like that to be walking around and suddenly decide and discover that. Oh wow, I didn't know that was even there. Whereas we would have already been walking or had our foot propped up for a couple of weeks, right? They don't even know it's there. And if they're not checking, we need to be sure we're checking, okay? Most common cause of hospitalization in diabetics. Risk factors are neuropathy, peripheral artery disease, smoking. Hopefully there are not many diabetics smoking anymore, but I'm sure there are. Clotting abnormalities, impaired immune function, and autonomic neuropathy. Some of the other skin problems, acanthosis, nigricans, necrobiosis, granuloma, annulera. All of these are things that you're going to see diabetics. Infection, they are more susceptible to infection. Have an impairment of neutrophils and monocytes, loss of sensation, we already talked about. They require prompt, vigorous, aggressive treatment of all infections. You do an assessment, take past history, viral exams, or viral infections, medications, obesity, weight loss, thirst, hunger, poor health, too small breathing. Diagnosis, this is a very, very short list for a diabetic patient, okay? Ineffective healthcare, self-care management, risk for injury, risk for infection, powerlessness, imbalance of nutrition, skin integrity issues, neuropathy, increased or decreased sensation, decreased healing. Every system in their body is at risk. Overall goals are active patient participation. If you do not have their participation, if you do not have their motivation to take a part in their health care, you've already lost half the battle, okay? Motivate them some way, find a way to motivate them. If it's their grandchildren or if it's something, give them short goals because it is hard work. How many times a day do you think a diabetic sticks their finger? I mean, and those, let's talk about that older generation again, okay? My buddies, my peers. When they're on fixed income, okay? And they have to stick their finger at least 4 times a day to get proper management. That's $4, at least $4 a strip, you know, because each strip's over $1. That's $4 a day to get their strip. You know what, in home health, I used to hear them tell me all the time, I feel like, I played that game with my elementary students because I want them to kind of zero in on when they're in trouble. But I have the other extreme with my elderly patients who are on fixed incomes who could not really afford those strips. So they said, well, I feel like I'm 200. Let's give me some insulin for that. I feel 200. Like, no, we really need to check that. Well, no, I really feel around 200. I'm going to go with that. And if I go low, then I'll take me something to eat. But do you understand why? When you don't make much money and you have and you're on a fixed income, that is huge. Do you know how much a bottle of insulin costs? Does anybody have any idea what 1 bottle of insulin costs? $300. You know how long that little bottle lasts? Do you know how much the pump supplies cost? I'm not talking about the pump, I'm talking about the supplies, the tubing. $1,500 a month. A pump is about $7,000 to $10,000. $7,000 if you get a reconditioned one. Diabetes is an expensive disease. And people who have it, let's be honest, are all across the spectrum, but people who have had a sedentary life, poorly educated, very poor diet, no access to health care. Do these people sound like people who have that kind of money? Really? Really, right? So they are already behind, and now they've got a very expensive thing to help, to take care of. And it's a lot of work. It's just reality of where I've found many patients have lived. And it's really sad to see them suffering complications, mainly because of their choices that they made, but sometimes their choices are made not because of they don't care, it's just where they live, where they're having their realities. So maintaining normal glucose levels is hard, and preventing complications is hard, and making those lifestyle adjustments is very difficult. Meet them where they are, give them goals that they can work toward, motivate them, give them small successes, because it's when they get a little success that they might step out and do something more, okay? So health promotion, identify those at risk, routine screening, diet, exercise again, intervene for hypoglycemia, ketoacidosis, stress of illness and injury, surgery puts up glucose, help them with a meal plan. Listen, we won't even talk about having the money for a healthy, balanced meal. What foods are more expensive?
Healthy.
The healthy ones. It always has amazed me that the less a grocery store has to do with the less processing you have on a product, the higher it is. It's like, why is it that an apple that you pulled off a tree is more expensive than something that's been processed 20 times and boxed up? It's like that, all you do is pull it off the tree and it's that, but yet this thing here that has no nutrition in it whatsoever, it's been through so many processing lines. Oh, you can afford this. The pseudo food to be created, but that apple, no, that's expensive. So you have to think when you're your patients, like I was telling you, you know where they are. Don't send them home on a discharge plan that's a pipe dream that they have no way of ever achieving that. Frequent blood sugar monitoring, hold metformin before surgery, then for studies that have contrast. Overall goal is to enable the patient or caregiver to reach an optimal level of independence. meet them where they are, get them as far as you can get them to be, that they're able to be. Your goal and their goal may not be the same, but help them reach their goal. Insulin therapy, with oral agent therapy, personal hygiene, medication identification and travel card. They need to carry, because if they're out and they go out from hypoglycemia, what do they look like if you've ever seen anyone? What do they look like? They kind of look drunk, don't they? Someone who's going out, they're confused, kind of looking drunk. Medical alert card will help people identify and know that there's someone if they are in trouble. Family and patient teaching, especially education. Teach about blood glucose, exercise, food, medications, guidelines, foot care, checking their skin. Self-monitoring, assist in making decisions regarding their diet or medication. It helps detect high glucose levels low. Training is crucial. Having the supplies is necessary. There are new pumps and new glucose monitoring systems that will give you a constant readout. Those are wonderful. I have seen the whole gamut of diabetic monitoring. When I was little, I can remember this is how we used to check glucose, okay? We had a little glass tube, and my sister and brother at that time, the only two that had it at that time, would have to urinate in a cup, and then my dad, I can remember this so clearly because he was so methodical in making sure he did it right, you know. So he would put the urine in the little tube, and then he had these little tablets he would drop in, and then after he would let it stand for some, it's kind of like what you do when you're checking your pool water now, okay? And then he had a little chart that he would hold it up to see if they were 1+, 2+, 3+, or 4+ glucose in their urine. And then he would base their insulin on what that plus was based on that pool reading, okay? And I thought at that time that everybody must have insulin for breakfast because he would carefully draw up their insulin, have it laying there every morning by his plate. So whenever they came to have breakfast, he would give them their insulin. Their food was always, my mom would carefully measure out their food. I didn't get insulin for breakfast. I thought, what's wrong with me? Well, them get this and what's wrong with me? You know, I thought everybody had it. Stupidity of childhood, right? But then they went to, the insulin, and they went to the insulin pen, and now we've gone to the handy dandy pump. The pump has been a wonderful thing. It's changed diabetes, the lives of diabetics. It's a wonderful thing. I don't knock it at all. My problem, when I see one of these, is I go back to my little guy that I sent out by ambulance. He came to me about a year, probably, after he was a diabetic, and by then he was a little cocky high schooler. Thought he was all that in a bag of chips. He came in one day and he was having some troubles, and we had a conversation. And his parents were still very busy in their lives, and Dad was still a coach, and his mom was still running her business, and he was spending a lot of evenings at home alone. So he was having some major glucose problems, and that day when he came in, his glucose was really high. It was like 450 or something. I'm like, dude, what is going on with you? What are you eating? So we sat down and had a conversation, and he informed me that when he went home every evening, in his boredom and in his aloneness, he ate an entire package of double stuffed Oreos every evening of his life. And I'm like, you can't do that. Oh, yes, I can. I do whatever I want. No, you can't do that. My dietitian told me I have a pump. I have no dietary restrictions because I have a pump. I'm like, honey, you do not have dietary restrictions because of your pump and your diabetes. I said, you have dietary restrictions because you're a human being. And no human being can eat a whole pack of double stuffed Oreos every day of their life and expect that they're not going to have repercussions. Oh. Now, I'm sure you continue to eat this double stuffed Oreos. But that is the mentality, because I immediately called this hospital dietitian and gave her a piece of my mind, that you need to give them the fear of what this disease is going to cost them. Oh, we don't like for them to be afraid. We want them to be comfortable. Like, you're teaching them a lie, because they need to be afraid. And he needs to not eat a whole bag of Oreos. So we need to be honest with them. We need to be honest that you have this disease, there are things you can do to manage it, but you have these obstacles ahead of you. And you have these consequences ahead of you if you don't take care of yourself. So pharmacology, there's insulin, there's oral, non-insulin injectables, there's aspirin, ACE inhibitors, all kinds of things to treat all kinds of things that are going wrong, right? Nutrition, I don't see Oreos on there anywhere, you guys. Healthy diet. High protein diets are not recommended. What does protein do to your kidneys? The challenge for them. And if they're already challenged with glucose, protein just adds to that. So a balanced diet, not too much of anything. Minimizing fat, a moderate amount of alcohol. Exercise at least 150 minutes a week, for 30 minutes 5 days a week. Moderate intensity. Don't injure themselves. Resistance training if there's no contraindications. Supplemental and alternative therapies, again, all of these should be used with caution. There are no real studies that have evidence that anything hurts them or helps them, but they have their right to try these things if they so choose. They just need to be warned to use them with caution. Gestational, most common disorder of pregnancy. High-risk pregnancy can be successfully managed. Key, of course, is strict glucose control. Seen in about 9.2% of the United States, gestational is impaired tolerance for glucose. Its first onset is during pregnancy. Usually disappears a few weeks after delivery, but unfortunately 50% of clients will develop type 2 diabetes later in their life if they have gestational diabetes. It also poses risk for the fetus. Early screening, as I said, if someone is very susceptible, they're going to test them earlier, but otherwise standardized screening is usually between 24 and 28 weeks. Risk factors, the same things over and over again. Obesity, family history, hypertension, previous delivery of an infant that was large or was stillborn is a risk. Increased risk for developing, like I said, type 2 within 5 to 10 years. Fetal and neonatal risks are a mortality risk, congenital malformations, respiratory distress, intrauterine fetal demise. Interventions, diet, exercise, monitor their glucose, restrict their carb intake. Therapy, we go for the diet, exercise first. Then we go for insulin if we need to. Most oral agents are contraindicated in pregnancy, but glyburide is one that can be used, but most others are contraindicated. So go for the nutrition and diet first, and do fetal surveillance to have them like count how many weeks and such they count. Glucose monitoring hourly during interpartum. Insulin infusion if you need. Avoid dextrose. Postpartum, most return to normal, but higher risk for future pregnancies. Increased risk for diabetes type 2. Follow-up care is 6 to 12 weeks to assess their status. 24 weeks is when you do the oral glucose tolerance test. Drinking the nasty stuff, and then we check your glucose 1 hour, 2 hour, and 3 hours after drinking your glucose concoction. Any questions? Clear as mud. If nothing else, I hope I've at least got you thinking that, gee, if they ever tell me that I've got diabetes, then I'm gonna do everything I can to stay away from that, right? I wouldn't, it's just amazing how much the care for diabetes has changed over the years, but it's still a nasty disorder. How about we take a 5-minute break so I can feel my legs?